Today we are going to look into the common nutritional problems in geriatrics. The common nutritional problems includes osteoporosis, obesity, malnutrition, degenerative diseases, neurological dysfunction, etc. WHO states that the number of proportion of older persons above 60 years of age are growing in virtually in all countries. There was around 605 million older population in the last decade, and it is expected to reach 400 million in 2025. The number is expected to reach more than 1.2 billion. 71% of acute hospitalization in older patients is due to the nutritional risk or malnutrition, and this increases the mortality rate. Aging is considered by decreased organ functions, weakened hemostatic controls, increased heterogeneity among individuals, which is influenced by genetic and environmental factors. Various factors that influence the nutritional requirement in older adults include specific health problems, related organ system reserve compromise, level of activity, energy expenditure and caloric requirements, and mainly the ability to access, prepare, ingest and digest food and personal food preferences. Let's move on to the objectives of the topic. It is to analyze the common nutritional problems in geriatrics, to assess the problems and know about the effect on nutritional status, and to understand the dietary and lifestyle modification required to improve the health status of the elderly. Now, let's see in detail on the nutrition related problems in geriatrics. The elderly are at a risk of poor nutrition due to economic pressures, poor dentition, reduced mobility, depression, loneliness, aging tissues, and inadequate food consumption. Moving on to osteoporosis as one of the main nutritional problem. It is the condition where there is a loss of bone mineral density due to increase in osteoclast bone resorption activity and a concomitant decrease in the osteoblast mediated bone formation. There is a generalized bone disease characterized by low bone density and microarchitectural deterioration of bone tissues. It is primarily found in ideal age and elderly women who had early menopause and had sedentary life. The early manifestations are an increased incidence of bone pain and of back pain in women. Its major symptom is an increased vulnerability to bone fractures. The age at which bone mass is at peak in the population is 25 to 30 years. In young people in good health, the rate of calcium resorption equals that of bone formation. As people age, resorption begins to predominate over the bone formation, eventually resulting in osteoporosis. In osteoporosis, the total amount of bone is reduced, but the remaining bone is of normal composition and quality. Due to the reduction in number of cells, there is a decrease in thickness of the cortex, a thinning of trabeculate, and increased porosity of bone. As a result, fractures occur with greater frequency. Common fracture sites include the vertebrae, femur, and radius, and often these occur in spite of little or no trauma. The rate of femoral fractures alone doubles for each decade after the age of 50. The cause of osteoporosis may be age-related changes such as decreased estrogen production associated with menopause. The decline in circulating 17-beta estradiol is the predominant factor in the accelerated bone loss that begins after the menopause and continues for 6 to 8 years. Decreased intestinal absorption of calcium and production of vitamin D, reduced physical activity, and increased parathyroid hormone secretion may also cause osteoporosis. inadequate protein intake may contribute to osteoporosis in the elderly. Men also suffer from osteoporosis. The compact bone mass in the vertebrae is responsible for humped backs, characteristic of many elderly people. Dissolution of the jawbone is another frequent symptom of osteoporosis. It is a major contributing factor in periodontal disease, resulting in premature loss of teeth. Although aging is one universal and unavoidable factor that brings a risk of osteoporosis, many avoidable risk factors like sedentary lifestyle, emotional stress, inappropriate diet may contribute for osteoporosis. Low calcium intake and family history of osteoporosis are significant risk factor for low bone mass. The treatment with calcitonin and estrogen are prescribed for osteoporosis. Calcitonin inhibits the reabsorption of bone calcium into the blood but has only a relatively short-lived beneficial effect of 1 to 2 years. Estrogen therapy in postmenopausal women has been shown to slow the rate of bone loss, although it does not stimulate the new bone formation. It is much more effective as a preventive measure begin immediately after menopause than as a treatment of osteoporosis that has already developed. In the longer term, estrogen treatment results in increased parathyroid hormone and 1,25-dihydroxy vitamin D synthesis, which may explain the observed improvement in the intestinal absorption and renal reabsorption of calcium. It is logical for old people to take a diet with ample calcium, that is to drink 2 to 3 glasses of milk regularly. Some old people have a markedly reduced capacity to absorb calcium from the gut, and in such patients, therapeutic doses of calcium salt might be of benefit. Adequate protein along with calcium also helps in the formation of bone tissue. Plant-based estrogens or phytoestrogens are used as an adjunctive therapy for alleviating the symptoms of menopause. Phytoestrogens are non-steroidal estrogens of dietary origin. Phytoestrogen in soya, which is the isoflavones, may reduce the incidence of hot flashes, which is one of the important symptoms in the menopause. Soya isoflavones may also protect women against osteoporosis by the action of genistein, which is the effect similar to estrogen. It stimulates osteoblasts, the bone forming cells. It is sensible to encourage all old people and especially those with radiological evidence of osteoporosis to be as physically active as possible. The more they are on their feet, less is the risk of pathological fractures of the femur and the spine. The most effective preventive measures are ensuring calcium intake in adequate amounts throughout life and adopting a lifestyle that involves regular exercise and avoiding risk factors. Weight-bearing exercise may help increase bone mineral density by imposing stresses through repetitive impact loading. Resistance training may help by exposing bone to varying loads and rates of strain. Improved muscle strength may enhance coordination and balance and protect against falls and fractures. Although an exercise regimen that includes both weight-bearing and resistance training routines has a greater impact on bone mass density, even a simple weight-bearing program performed at moderate intensity may be beneficial. Exercise combined with adequate calcium and vitamin D intake may have a modest effect on showing the decrease in bone mineral density in postmenopausal women. Milk and sardines are good source of vitamin D. Indian scenario shows the life expectancy of both men and women in increasing rate. However, this increased longevity is associated with increased burden of age-related morbidities, including osteoporosis. Studies conducted by NIN in low socioeconomic groups shows that osteoporotic hip fractures occur at least 10 to 15 years earlier in Indians compared to the Western region. However, populations from high economic group in India do not show this early age of fractures. A few studies from India suggest that osteopenia and osteoporosis may occur at a relatively younger age in the Indian population. However, The prevalence of fractures of the spine and the forearm goes undetected in India because they are usually treated as outpatient cases. Studies regarding the bone density values of the Indian population involving large sample size are, however, not available. This is important because Indians from low economic group subsist on diets that have inadequate calcium coupled with low calories, proteins and micronutrients. In addition, they have low body weights and women attain menopause at an earlier age than their Western counterparts. It is possible that these women are at risk of osteoporosis and fractures at an early age. In the near future, developing countries like India may expect the occurrence of hip fractures in epidemic proportions. Osteoporotic fractures, especially hip fractures, are associated with considerable morbidity and mortality and increasingly high economic and social cost. Moving on to the next nutritional problem, the obesity. Some of the elderly are obese because their consumption of calories has not decreased, though there is steady decrease in caloric requirement. Sedentary lifestyle may also be a contributing factor. Obese are susceptible to diabetes and mortality rates may be higher. Moving on to the next problem, the neurological dysfunction. Problems of disorientation and slowing of neurological functioning both seen in the elderly. This have been attributed to various nutrition factors. A lack of niacin has long been associated with the dementia and depression. Deficiencies of vitamin B6 and thiamine are associated with the central nervous system problems. Women who walk or exercise regularly are less likely to experience the memory loss and other declines in mental function that can come with aging. Moving on to anemia. Anemia, characterized by feeling of fatigue, anxiety, lack of energy and sleeplessness, is a common result of inadequate iron. Iron inadequacy can be caused by low dietary intake, impaired absorption, possibly resulting from lack of heme iron or vitamin C or blood loss. Treatment may involve using iron supplements together with the diet providing iron sources of high bioavailability and vitamin C to enhance the absorption. Pernicious anemia is seen chiefly in middle ages and elderly persons. Plasma vitamin B12 is below 116 mg per liter, while folate is usually normal. Hydroxycobalamin should be given in a dosage of 1000 microgram. The diet should include animal foods like liver, egg yolk, shrimps and curd. Moving on to the next problem, the malnutrition. The important cause of malnutrition during the old age are poverty, inability to move around easily, cumulative effects of chronic diseases necessitating multiple medications, social isolation, and lack of knowledge for adequate preparation of meals. The studies conducted by NIN showed that the average daily intake of majority of nutrients bearing calcium, iron, vitamin A, thiamine, riboflavin and vitamin C were below the recommended levels as evidenced by the low level of consumption of protective foods. Malnutrition is common among old people who are institutionalized. According to the studies, the prevalence of chronic energy deficiency is significantly higher among the elderly than their adult counterpart. With increasing age, there is decrease in consumption of food and nutrients. There is a need to develop and implement appropriate programs to improve the health and nutrition in particular among the elderly population in India. Moving on to the next common problem, which is the constipation. It is the infrequent passage of stools which are most often attributed to prolonged rectostigmoid transit, reduced elasticity of intestinal wall muscle, fewer meals, low fluid and fiber intake and depression can cause drier or harder the stools than the normal one. Generally, it is uncomfortable and elimination can be difficult and painful. Common symptoms of constipation include bloating, sluggishness, a feeling of fullness in the rectum and a general sense of feeling out of sorts. The stools become hard and dry because the stool moves too slowly through the colon. The natural contractions or rhythms of the colon might be disturbed due to loss of tone, stress, medication, illness, resisting the urge to defecate, pain from hemorrhoids or tissues, lack of exercise, a low fiber diet, or not drinking enough fluids. It may even be caused by overuse of stimulant laxatives or enemas. In the elderly, it may be related to inadequate energy intake, fewer meals per day, depression, and sedentary lifestyle. Constipation can be prevented by eating regular meals, drinking plenty of fluids, and regular exercise. One should respond to the urge to move bowels and avoid straining. By adding fiber to the diet, constipation can be prevented. Moving on to the next important problem, degenerative diseases. Blood pressure continues to increase in women older than 60 years of age, but substantially in older men. Serum cholesterol levels in men tend to peak at 60 years of age, but total cholesterol level as well as the low density lipoprotein fraction continue to rise in women until the age of 70 years. Correction of hypertension and hyperlipidemia have been shown to reduce the cardiovascular morbidity and mortality in the elderly. Renal function and glomerular filtration rate can diminish as much as 60% between the ages of 30 and 80 years. This may be due to certain chronic conditions which reduce the number of nephrons and reduce the blood flow. This makes the elderly person less able to respond to changes in fluid status and to challenges to the acid-base balance. Geriatric nephropathy may be a result of chronic protein over nutrition. Oxidative stress promotes the process of aging. Lower red cell activity of glutathione peroxidase was observed in the elderly. Such decrease might be a precursor to oxygen-mediated damage to the tissue, an incident of degenerative tissues. Disease like diabetes, atherosclerosis, hypertension, cataract formation, Parkinson's disease, Alzheimer's disease, and cancer that occur during old age may be related to low intake of antioxidants. With aging, there is decrease in glucose tolerance. Vitamin C, which is an antioxidant, plays an important role in preventing of complications of degenerative diseases. The free radicals are implicated in the cause of atherosclerosis. Studies have shown that vitamin E retards the development of coronary artery disease. Cataract is the opacification of the eye lens, which interferes with the transmission of light onto the retina. The UV radiation may damage the cells like lens protein by degenerative reactive oxygen species. Antioxidants prevent susceptibility of lens protein to UV radiation. Studies have shown that people with low serum carotenoid level had more chances of developing cataract than those with normal levels. Cataracts can be prevented by making the diet rich in beta carotene, riboflavin, and ascorbic acid. Consumption of beta carotene may reduce the risk of macular degeneration. Studies have also shown that elders who take sufficient amount of omega-3 fatty acids have better visual acuity. The incidence of cancer increases progressively with age. Persons with high antioxidant intake are less likely to develop cancers. Dietary factors may interact with the disease causing or predisposing the genes in molecular degeneration of neurons. Epidemiological findings suggest that high caloric diet and folic acid deficiency increase the risk for Alzheimer's disease and Parkinson's disease. High homocysteine level have implicated as one of the causes of Alzheimer's disease. Supplementing with vitamin B6, B12 and folic acid are helpful. Lipoic acid and coenzyme Q and herbs like ginkgo tea may be useful to the patients. Reducing the calorie intake has also been found to be much help. The dietary modifications may be helpful most with cognitive impairment rather than advanced dementia. Keeping the patient mentally active by encouraging reading, making them to solve puzzle is important. Reciting slokas and singing may also be helpful to the patients. Resistance to disease declines in the elderly. Change in immune system can be overcome by taking 200 mg of vitamin E. Protection from DNA damage is believed to enhance the body's self-defense mechanisms. Damage to the collagen fibrous network underlying the skin by free radicals can result in sagging of the tissues, appearance of fine lines and wrinkles, and discoloration of the pigment. This can be slowed down through nutrition or antioxidant supplements. The elderly are more prone to disease due to lowered synthesis of antioxidants in the body, reduced food intake, physical activity, and resistance to infection. The elderly need more calcium, iron, zinc, and vitamin E and vitamin A to prevent the age-related diseases. Evidence shows that 600 grams per day of antioxidants rich in fruits and vegetables should be taken by the elderly person. To summarize, the elderly are at a risk of poor nutrition due to economic pressures, poor dentition, reduced mobility, depression, loneliness, aging tissues, and inadequate food consumption. The major nutritional problems including the osteoporosis, obesity, neurological dysfunction, anemia, malnutrition, constipation, and degenerative disorders are faced by the elderly. This could be counteracted by proper nutritional care with proper food.